Nothing contained in this podcast should be considered a substitute for professional medical advice. This content does not represent our respective employers and is purely the opinion of the podcast hosts. We are not your personal medical providers. Sorry, friends. So, if you have any questions or concerns or are seeking advice, diagnosis, and or treatment, please seek individual, personalized advice from a healthcare provider in your area. We are not liable for any risks or issues associated with using or acting upon the information contained in this podcast. This is intended for educational and entertainment purposes only, so enjoy the ride. Welcome to Medical Media Mixer, the perfect cocktail. I'm Nicole Peniston, licensed psychologist.
And I'm Tara Prisco, physician assistant. All right, double ones, episode 11.
11/11, it's supposed to be good luck.
Yeah, Laura used to always say 11/11, make a wish.
Yeah.
I know she's been listening, so this is your second shout out, okay?
We're making a wish for you. Our wish is that we have more listeners and people send us emails.
Oh, so I have something. Mm-hmm. So I sent you those pictures yesterday, right? So I'm digitizing my mom's literal cassette tape home videos. Mm-hmm. And we have our high school graduation, and alphabetically, we happen to be right near each other, which I don't know why I was ahead of you, because I was PO. And
it's weird because I know that the twins were always ahead of me.
Yeah. But
and then there were other folks.
I think it was like two lines forming and coming together maybe, but you and I ended up either way. So we have I took some screenshots of us chatting in line about to go up and get our diploma. So maybe with your permission, we can do a little social media post.
I'm okay with that.
Of our younger selves.
I mean, I feel like we don't look that different now, so.
I mean, I was looking at some of these
haircut in that picture, but we can't Photoshop that. So
I was looking back and I was looking how thick my hair was in the old, and I don't have not thick hair, but I was like, it was just so lustrous, and I was like, what happened? I guess you get old. Well, but it was just funny because I was clicking through a bunch of her old stuff. I haven't gone through all of it yet, but it was worth doing so that we'll always have now digital files of these things. Yeah, so it's pretty neat.
Well, it's funny. I read your message. I didn't look immediately at the pictures. And the first thing I thought is I remember so little from our graduation. So little.
Yeah.
I remember one of our speakers, which I later found out was high. I remember sitting in the gym, but I don't really remember much else of it. Yeah. Oh, no, I remember standing outside because that was when, speaking of Laura, her little sister was born. Wasn't she born on that day?
No, she was born on her 16th birthday.
Well, okay.
So if they were there, she would have been a year old.
Yeah.
She's 20-something.
Yeah,
so.
She's a full-ass adult.
And it was interesting because we graduated May 31st, which wasn't even June, so early.
Yeah.
It's crazy. But yeah, I actually have the video of me getting ready, and there's a boyfriend from when I was in high school who's in the videos and stuff too.
I remember this boyfriend.
I doubt he listens.
Probably not.
Maybe his parents do. They always liked me.
Maybe. As they should.
Oh my goodness. Any other random happenings or future happenings?
No, nothing too crazy going on. I feel like January always lasts 73 years, and then February's over in a blink. So it's we're already past mid-February, so
right
before we know it.
It's true. That one less day or whatever, 2 less days in the month, somehow it makes it a blink. We are supposed to possibly get snow on Thursday, and so when I looked at it yesterday, it said 11 to 21 inches.
Mm-hmm.
But then I looked at it today, and it said 4 to 5.
Well, that happened last week where they were predicting between 5 and 8 inches on Tuesday, and it was supposed to snow several days in a row. And then I ended up changing all my patients to telehealth on Wednesday, and it was nothing. But everything was already telehealth, so they'd all just stay home. But
that's fine.
Yeah, it was crazy, and I feel because we had that happen 3 times already, we're gonna get hit with the big one. It's no warning.
Hey, if I get to stay home, that's fine. Exactly. But if it's just on the edge of it could go either way, then it's
that's when it's frustrating, yeah.
And delayed opening for kids is not conducive to working. So it's all or nothing here.
I get it.
And then also, but if they take a snow day, then they lose a day off later. So I don't know, whatever.
Well, that sucks for them, but not for me. Sorry.
Yeah, that's true. All right. What do we got for today's episode?
So today, my cocktail is called the Imposter. Credit to Sabrina Eldridge of Nerd Friday.
Oh.
So there's like a little cute narrative about the drink, but I'm just going to tell you what the ingredients are. So this is why it took me so long. In a large pitcher or jar, add 5 sprigs of mint, just the leaves, no stems, half a cup of blueberries, 3 tablespoons of lime juice, muddle them together until the berries are smashed and the mint is lightly bruised. And you add 3 cups of pineapple juice, 2/3 of a cup of sweet and sour mix. And then you stir it together. You fill. So this can be non-alcoholic or alcoholic. So this is all the same until now. So if you want to make it alcoholic, you fill a glass halfway with that mixture. You add an ounce or 2 of your favorite clear alcohol. I put in vodka, and then you stir it with a mint sprig and top with sparkling water or club soda. So that's what mine was. If you want to make if you want to make it non-alcoholic, you just pour the mixture until the glass is 2/3 full, and then top with sparkling soda and garnish with mint.
Nice.
So that's my drink. So you may ask, why are we drinking the Imposter today?
Right.
Because I'm going to talk about something called Capgras syndrome, or Capgras, as us Americans like to butcher other languages. So have you ever heard of that before?
Not until I saw your notes.
Okay. So I got this from, I knew about this disorder, and I was trying to find a movie that did it well, but there's a lot of very campy movies or inaccurate presentations of it. So I didn't choose, that route to go. It doesn't really come up in too many TV shows because it's very complicated. But I did find a NPR podcast and brief article about it. And so there'll be a link to that in the show notes. But basically what this article is called and the podcast is called that podcast episode is called Seeing Imposters When Loved Ones Suddenly Aren't. And so basically what this is, actually I'm going to tell you. So when you listen to the podcast, it's very short. It's literally 7 minutes long. That's it. Not like ours. Sorry, guys. But they give a couple of examples of when someone has this. And so the first example that they talk about is how this woman went into her actually, I think this is just in the article, not in the podcast. So this is not a spoiler if you decide to listen for 7 minutes. But this woman, she goes to see her psychiatrist. And she says that she went home and she found this strange man sitting on her couch. And he was vaguely familiar and was wearing her husband's clothes. But she was like, that's not my husband. I don't know who he is. And she felt this odd experience when she was looking at him. And she just knew that this person, although he may visually look like her husband, was not. And it was her husband replaced with a strange person or an imposter. And so what this experience is, it is something that can actually happen. It's called Capgras syndrome. And so what that is, it's considered a rare delusional disorder, but it can actually occur from very many different types of things. It can occur from dementia. I think that's what we see a lot of times, and you may label Alzheimer's. It's a symptom of that.
Right.
People think they're being an imposter, or they recognize you, but they don't recognize you. Can happen from a traumatic brain injury, from schizophrenia, epilepsy, things like that. And so what is considered is a delusional misidentification. So they recognize the face, they see the person, and they visually recognize who that person is, but they believe it is not the same person it should be. They believe it's someone else impersonating someone. It's an imposter. And very rarely, this can also occur when someone misidentifies items. So they're like, that's my book, but that's not my book. It looks like my book. It's where my book was, but that's actually somebody else's book.
Wow.
And so that's even more unusual. It was first discovered in 1920 by a French psychiatrist named Joseph Capgras.
It's always the French. I'm telling you.
That's why I love France. And so it essentially what it is, even though it is a delusion, they believe that there's some impairment in the visual system where the processing between the brain and the visual system is out of sync. And so people, even though they visually say that, yes, that looks like so-and-so, or that looks like my thing, they don't believe that it actually is theirs. And so I have a couple of articles that'll be linked in the show notes. But we don't know for sure the one underlying cause. We just see it happen often in those situations like I just described. And so what often happens is that these people have a distinct feeling that someone, their loved one often, has been replaced. And someone has even described it as the soul of the person isn't there, that they get an empty feeling. They don't have that feeling of familiarity, that emotional connection with someone or something. And so they believe that this person is an imposter. So when we're listening to this podcast, they talk about a couple of examples, and they talk about what that experience is and how to treat it, which I'll talk about in a little bit. But the really kind of twist ending at it, at the end of it, was they're talking with, I believe she's a psychiatrist, is one of the women on the show talking about it. And then she's like, well, actually, my husband has that. And it kind of threw everybody for a loop. Wait, whoa, you're experiencing this day to day, which they seem to believe that it is a part of dementia with her husband. But just to talk about this and have it be so unusual, but then to be on the other side of it, to not have your loved one believe you are who you say you are, that's going to be really difficult.
Absolutely.
And in the article, I don't think she says this in the podcast, but she said that she hopes that he'll recognize her when she walks in the door, but it can vary from day to day. And so she never really knows what she's going to get into when she goes home, and stressful that can be both for the person experiencing the syndrome, but then the people on the other end of things. So let me tell you a little bit more about it. So like I just said, people believe a doppelganger looks and acts exactly like their original person, but they're still an imposter. You can't really argue or reason with people to get them out of it. And it's rare. It doesn't happen very often, but it does fall under delusional disorders, which we've talked about on other episodes, different types of delusions. And like I said before, we believe that it is part of an impairment in the visual system. I'm not going to go too deep into that, but there's some evidence for that visual processing theory because there's been case studies of people who have it. When they saw them in person, they thought it was an imposter. But when they spoke with them over the phone, they knew that it was the right person. So something about the visual.
That's so really interesting.
Yeah, very interesting. So basically, the way to treat it is if there's an underlying psychiatric or neurological cause of this, we want to treat the symptoms of that larger disorder. So if someone has schizophrenia or dementia, trying to get them to take their medications, and hopefully that will reduce that experience of not believing that person is who they say they are. And then if somebody has a traumatic brain injury, making sure they're getting the right rehab to recover from that injury. But also people can benefit from therapy. And so that's more of reality orientation, behavioral therapy. So helping people more manage the delusions and manage the emotions versus getting rid of them. So you're not going to sit and argue with someone and say no, this is who you say they are. They're not going to believe you because their brain is telling them it's not, but telling them, okay, when you're with this person and you feel like it's not who it is, what is going to make you feel safe? Can you develop a cue word or something that'll help you feel comfortable with them? If you're feeling anxious or confused, what type of skills can you use? What type of coping skills can you do to manage those emotions when you're around that person? It can be really difficult, like I was saying before. I think the most important part of this is to realize this is not intentional. These people are probably scared and confused. They're not trying to screw with you. They're not trying to be mean. They just really don't feel like they recognize that person. That can be really scary, especially when it's someone that you visually are like, wait, that's my husband. Wait, no, it's not.
Yeah.
And then just, caring for someone who has that, it can be really devastating, like I was saying before, to be on the other end of that. So being in your own therapy, whether it's supportive therapy, talking with other family members who are experiencing the same thing, and learning how to manage your own reactions to that so you don't kind of stir things up and make the other person even more agitated than they may already be. So there's some studies that say that Capgras syndrome or Capgras has been associated with the anxiety and hallucinations that we often see in Lewy body dementia, but I know that it can come up with other sorts of dementia as well. So there's a link to that, which is interesting. I'm not going to go too much into that, but that can be really difficult dealing with someone who has Lewy body dementia because that can present differently than other types of dementia, which that's for a whole nother episode. I'm sure you know a little bit about that, but
a little bit, but not super deep. It's tricky to diagnose.
I think the big difference is a lot of times when someone has that type of dementia, one, we call it Lewy body dementia because we're seeing something different happening neurologically, but they tend to be more anxious or have hallucinations, seeing people or hearing things that are actually not there. And so I feel like that goes along with that disruption of the visual system that we see in Capgras, because they're seeing something that's not there, but they never had those experiences, those hallucinations prior to the dementia. So it's definitely something neurological that's going on that's upsetting those systems and the connections in the brain. And then finally, there's just another article just explaining what it is. It's, like I said, it's very rare. So more than likely, most people are not going to meet someone who has it or not going to experience it themselves. But there's enough out there that we know that it actually happens.
I can imagine, you said TBI, imagine stroke can also probably.
Yeah. So when we say traumatic brain injury, that can be an acquired traumatic brain injury, like stroke, traumatic brain injury is acquired. So something that's happening to you, or it can be one that is caused internally. So like stroke, things like that. So TBI is just the larger overarching term. Okay. So there was a study back from 2012, so a little outdated, but we saw Capgras in psychiatric populations less than 1% of the time. So that's how rare it is.
That's pretty rare.
Yeah. And then, because I think that is something different than the type of delusions or hallucinations you would see in someone who has schizophrenia. So it does present very differently. And I think it is very difficult to treat. There is another study here from 2007 that some violence and aggression is related to experiencing this, because like you can imagine if you're sitting at home on your couch and a stranger walks in your house and starts talking to you like they know you and you don't recognize this person, you want to defend yourself, you're scared. And so these people can get aggression, can get aggressive, can get violent. And it says that I'm trying to find out where this was because this is the high number. 2019, a systemic review of 255 published cases, 6% of them resulted in homicide. So these people actually killed someone because they thought this was an imposter.
Do they mention anything like
that in context? If 1% of the population has it, 6% of those people.
Right. It's still very small. But do they ever like associate, or do the people who have it say it's like an alien or a ghost inhabiting them? Like, how do they sort of explain it away?
They often explain it as someone is an imposter. It's another person. It's just not their person.
Okay.
So they're not thinking like it's an alien abduction or like you were saying, like a zombie or something otherworldly. It's just another person pretending to be their person. The other thing, and I can't find it now, but it's definitely in one of the links. There was a study about if that occurs when the person looks in the mirror. I don't believe it occurs when they look in the mirror. And I'm going to talk on a different episode about face blindness, which is not the same as Capgras. That's actually how I got to this. I was studying face blindness, and then I was like, oh yeah, there's that thing too. They are two totally different things, so that's why I'm talking about them separately. But I do believe these people will recognize themselves as themselves in the mirror, but I can't find that citation right now. So don't misquote me, but I feel like it's somewhere. And then the differential diagnoses, like we talked about, delirium, which anytime someone's having hallucinations or delusions, we want to go about first. And just so people know, delirium, the difference between delirium and psychosis is delirium is short-term, and it's typically caused by an infection or a medication or something like that, even though the behaviors on the outside may look similar. And I think that's all I got, unless you got questions. But I probably can't answer.
I mean, yeah, just trying to wrap my head around the whole thing. It's a hard concept, but I can imagine the brain does amazing things. So it's taking that visual input. And it was interesting when you said you split the visual and then say the sound, and just sound they recognize. So I wonder if something like a videotape of the person, like a video, like recording.
Yeah. And I think that's hard because I wonder if part of it is so just think about it like this way. If you're sitting in a room with your kids, that's a different feeling than if you see a photo of them.
Right.
So I'm wondering if, again, that visual system, because it's different, your reaction may be different to those two different types of stimuli.
This is completely out there. Wasn't there that horror movie with a whole copy of the whole family comes?
Us?
Yeah.
I didn't watch it, but yes, it was one of the things that was cited. I think that's a little bit different. And there's a bunch of movies out there that say that they're about this, but none of them truly capture the real aspect of it. So like the one always cited is Invasion of the Body Snatchers.
Right.
But that's a literal alien invasion of people doing that. It's not someone having this misconception of it. And I really wanted to like talk about what the actual
true to it, not these random things. But I mean, the whole thing is very disconcerting, and I'm sure very frightening for the individual, and then stressful for the family members. And it's typically one particular person that they feel this, not everybody.
So that's the thing. It varies. It can be feeling. So I'm just reading this article. It says a false belief that an identical duplicate has replaced someone significant to the patient. So it's someone important. Doesn't necessarily have to be just one person. Tends to be a big reaction to one person. But they said it can also be an inanimate object, like I was saying before, or an animal, which is like really sad. Because like if they think their pet is not their pet anymore, like the pet doesn't understand. It's hard enough for us to understand.
That's so sad.
Yeah. But I think, it's so sad on both ends because both people are in such distress about this.
Yeah.
And then this says these neurophysiological deficits cause an inability to integrate emotional information processing and facial recognition. So that was kind of answering that question that you said.
Yeah.
Yeah. And then other than, like I said before, schizophrenia, Alzheimer's, dementias, epilepsy, CVAs, cerebrovascular accidents can cause it, pituitary tumors, advanced Parkinson's, something I've never heard about before, de Clermont syndrome?
De who?
De Clermont. I said it with an accent.
You're saying it with the French. Say it with the way that I would read it.
Clermont.
Don't know that one, but there is
Orange syndrome. I'm assuming those are neurological issues.
Yeah, there was something else I wrote down that I will not be able to cover, but because there's really no true movies or TV shows on it, but I had to look it up. Now I don't have the name of it here. It was basically another visual sort of processing-ish thing. It's in patients who have visual impairment. They can have as their vision declines, they can have vivid visual hallucinations, but it's not a psychiatric condition. It's their brain, I guess, giving them something to look at, if that makes sense.
Like phantom limb syndrome, but for your eyes.
Yeah, like happens at nighttime mostly. And, if they have poor vision, their brain starts to have these very vivid, bright images. So it's just so interesting how the input from each of these sensory organs can cause these different processes in your brain. It's amazing.
Yeah, it's very cool. And I just found another citation that violence, aggression can be very high in this population of people. So even though it's a very small amount of people, it's extremely distressing. And so these people can lash out. And so you want to get these interventions in there as soon as possible, especially if it's treating a psychiatric diagnosis, that all of these are highly treatable.
Yeah. Very interesting.
So it was a shorty, but a goodie, because I feel like it's something that makes us all think a little bit.
Yeah, it's weird. It's out there. It's strange.
Yeah,
and even found a drink to coordinate with it.
Yes. Well, I was shocked at that. And it was like, I don't know about you, but sometimes I'll search for drinks and I'll scroll through a bunch before I find one I like. This was the first one.
That's nice.
Yeah.
So when we get to my drink, it's quite literal. So
okay, I'm ready.
So Appendicitis Deluxe, or Delu. How do you say the French Luxe? I don't know.
The same.
Okay. So it's 1.5 ounces of gin, 3/4 ounce of lime juice, 1/4 ounce of triple sec. Take that in a shaker with some ice and pour it into a martini glass. So pretty straightforward. It's very light and refreshing. And it is actually from Absolute Vodka, is where the drink came from, even though you're not using vodka, you're using gin. But it came from their website. So
opportunities, welcome.
Yeah. Absolute. So what I'm covering is an old show, going back even further than my first one, from 1989.
Classic.
Doogie Howser. So for those of you who don't know about Doogie Howser, I'm sure, I feel like it's something we constantly refer to, though, colloquially. Oh, this young one, they're a Doogie Howser.
Well, it's funny you say that, because there was something, I don't remember where I saw it, but there's all these things that we colloquially, can't say that word too.
Yeah.
Things that we refer to, that the younger generation literally just uses the phrase and doesn't know what it stands for. So an example was hanging up the phone.
Yes.
People don't hang the phone up anymore.
I mean, when I was at work one day and I said I had to MacGyver something,
They were
Just
like,
a
what's
bunch of
happening?
blank stares. So, but Doogie Howser, so the opening of the show credits gives you sort of the whole story. So
It's all in my head.
I know. So it shows all these basic like news articles. So first one says 6-year-old scores perfect on the SATs. Next one, completed high school in 9 weeks. Graduates college at 10. Graduates medical school at 14. And then the show starts with him at 16 years old being a resident physician. So in each episode, it's usually framed by him typing into his very old computer diary with like the black screen and I think the green letters going
version, which people
across
don't even
the
know what that is
screen.
anymore.
And typically his best friend Vinny pops in through the window during an episode. Vinny is very New York, very loud, always enters.
And Vinny was in Newsies.
Yes. And they do reference in the earlier episodes. So this is season 1, episode 3. So I watched the first 2 episodes to refresh myself because it's been many years. That Doogie actually had acute leukemia when he was 4 years old and had a recurrence at 6 years old. So I'm sure that influenced his reason for going into medicine. So I'm talking about season 1, episode 3, and the name of the episode is called A Stitch Called Wanda. So Wanda,
no one will get.
yeah. So, well, okay. So it's a play on words on A Fish Called Wanda, which was a movie.
It was a movie about a transgender, which probably has not aged well.
Yeah, probably not. But in this, Wanda is Doogie's girl he's seeing, we'll say. And, the episode goes, in the first 2 episodes, him warming up to, getting to know her. In this episode, they're going out on a date. So they start out with Doogie arriving at her house to pick her up to go on the date. And he's 16, so he just got his driver's license. His father's making small talk with her and the parents.
Wait, you didn't mention the most important part of Doogie Howser.
What's that?
Played by Neil Patrick Harris.
Oh, yeah, of course. I know. Yes, Neil Patrick Harris.
Everybody will understand who that is. So
what's funny is he had between then and How I Met Your Mother, I don't know really what he did in those years.
Went to college to become a doctor.
Okay. Really big gap. But then now, he's done so much on Broadway. He was Lemony Snicket. He wrote children's books.
I met him and his partner last year at a drag show.
You did?
Yeah.
I am so jealous.
You should be.
I love him. So yes, I forgot to mention that. Thank you. So we start out, Doogie picking up Wanda at the house, making some small talk with the father. The father mentions that he and his wife are going out on a dinner cruise to Catalina. And, Doogie talks about, he's like, oh, yeah. And Doogie talks about how he amputated his first toe at work today, 16-year-old making small talk as a 16-year-old doctor. And the father kind of just gives him a nonchalant sort of reaction. So they, Wanda gets in the car and they start to talk about their plans. They're going to pick up Vinny and Janine, who's Vinny's chick, I guess she's dating. And Doogie sort of awkwardly asks Wanda to be his girlfriend and make it official. And she happily agrees. So during the movie, Wanda complains of a little stomach pain. Doogie suspects that it's because of what she's been eating. Vinny's in the back of the car after the movie now, pulling out Doogie's medical equipment, pretending to examine his date, just being silly. And he and Vinny and Janine leave the car to go, I guess, fool around in the bushes or something of that sort.
As one does.
Right, in the bushes. So Wanda's in the car with Doogie and they're going to kiss and, it's very quiet. And then all of a sudden she just starts having this abdominal pain that's more severe. And Doogie sort of recognizes this isn't normal. So he calls Vinny and Janine back to the car. We have to get to the hospital. So he pulls up to the hospital and apparently all of the surgeons are in surgery. There's no emergency room physician there. I don't really know what this hospital they work at is, but apparently Doogie needs to be her doctor, which, it's a little bit awkward. And he's like, we need to rule in or out appendicitis, and I need to do a pelvic exam on you. Right. So for those who are maybe either too young or of the male gender, a pelvic exam is basically a female gynecologic exam. It's an internal exam involving putting your hand inside the woman's vagina, feeling their ovaries and uterus.
So question, is that how we would check for appendicitis now? Because I know this was back in the 80s.
So typically now they're probably either going to do a bedside ultrasound or a CAT scan, and they're not even going to, this sounds bad with ER medicine nowadays, but that's going to be ordered before the doctor even walks in to speak to you based on your symptoms. But yes, I mean, traditionally, I'm not sure that exam is going to rule in or out an ovarian versus an appendix anyway, because your ovary and your appendix sit very closely together on that lower side.
Well, there's stuff in there you're feeling.
So honestly, I don't think that actually makes a difference, but they made a big deal about this in the episode, and it was very strange and awkward for them to add that in. But basically,
especially back then when we weren't so open about women's bodies and things.
Yeah. Although Doogie, I have to say, after watching the first few episodes, it was a little out there, like for its time. Like episode 1, they're talking about how, you know, who's going to get laid and sex, and, you know, teenage boys and testosterone. So I guess they were a little bit ahead of their time, sort of, in being a little open about this. It was a little cringy, some of the way they did it, but whatever. But basically, Doogie takes charge of her critical condition. No one can contact her parents, and she's a minor because remember, they're on a boat, and we didn't have cell phones back then. So.
And technically, HIPAA didn't exist back then. Which
True.
I feel like I hear on other podcasts people talking about informed consent and HIPAA and things like that, but those really didn't go into action until much later.
And really, honestly, if a kid shows up and they're not going to wait, they're going to save the child's life. If you show up a trauma from a car accident, no one's going to wait for your parents to sign permission. They're going to save your life and figure that out later. So they make a sort of deal about that. I think the more of the deal is the fact that he's being her doctor and they have a personal relationship, and it's strange. And he's only a resident. And so...
Wait, did you say this was their first date?
It was like their second or so date, but they became official.
Like, be my girlfriend, let me get up in there.
Right. So basically he and Dr. Fowler, who's another resident, end up performing the emergency surgery. Dr. Fowler's the handsome one with the long hair. And I don't know if you remember, there's also Nurse Curly, who's like the cute nurse who's always there. And there's a lot of fun little, you know,
I remember
characters.
The names, but not the
faces.
Can't put a face to the name right now.
Yeah. So basically she makes it through surgery fine, but afterward, Wanda's very upset over Doogie seeing her in a very vulnerable state during the exam and the surgery. And he, of course, gets reprimanded by the big boss of the hospital for admitting and operating on a minor without proper consent, which really isn't the problem. Like, again, it's because it's your girlfriend and you're a resident and you need an attending to do this. And all of that I see as the problem, not the fact that she's a minor. The fact that he's a minor and she's a minor, he's a doctor. So I guess, I don't know, all rules are out the window. Because I would think to get licensure, probably in most states, it probably says somewhere that you have to be 18. I don't know.
Well,
to become a licensed physician.
Also, he's a resident, so he should have been reporting all this to someone before you did anything.
Yes, you need an attending. Yes, you cannot do surgery without the attending there. It's a whole mess. But anyway, initially...
I clicked on your link and I just forgot how baby-faced he was.
He's so
young. He looks young, but he looks like he's 12.
Right, like 16. He's 16, but he looks 12. I agree. He looks so young. But, initially Wanda sort of distances herself from him, feeling embarrassed, but she comes around and understands how necessary it was for what happened. And apparently her appendix was already burst when he got in there.
Wow. So he really did save her.
He did. Yeah. And, so the episode ends with Doogie and his father sort of discussing the complexities of relationships. And his father is also a physician. So he has some experience in that. And then, of course, Vinny making jokes about the whole thing. Like, you got to see her naked. You got to see her insides. It's a little, but that's Vinny. That's what he's here for. The comic
relief. Nobody wants to see your insides. What's your serial killer?
So what is appendicitis, right? So, what is your appendix? First of all, your appendix is an organ. It's in your right lower quadrant of your abdomen. So sort of tucked in near your right hip. And your appendix is sort of a vestigial organ, as we call it. Something you have that we don't really know what you need it for or why you need it. And you can certainly live without it.
It's an accessory.
It is an accessory. Just, your tonsils, your adenoids, you can live without. Gallbladder has more of a function, but you can certainly live without that as well. So appendicitis is basically an acute inflammation of the lining of the appendix. And basically it still remains to be like a clinical emergency. Is one of the very common causes of acute abdominal pain. And we tend to think about it in younger populations, so children through 20s, although it can happen anytime in life, that's when it tends to occur the most. I don't know that we know why, but that's just when it is. So, they're going to list a bunch of different symptoms, and I'll sort of tell you what classic that we are taught. So they're saying the classic history is anorexia, so not wanting to eat, periumbilical, so around your belly button pain, that later moves specifically from that area down to your right lower quadrant, and vomiting occurs about 50%. Diarrhea and constipation can happen up to 18%. And you sort of see a typical body like position of the patient who's sort of guarding that area. They tend to lie down and flex their hips and draw their knees up to sort of brace themselves and avoid sort of shaking things up.
Like the fetal position, kind of?
Sort of, yeah. Your legs pulled up. And typically it happens within like a 48 hours that this all sort of progresses. And in elderly patients, it can be a little bit different. They don't present the same way. Again, not very common, but tends to be a longer course with them. On exam, the things that we're taught to look for. So first is that classic history, that periumbilical pain moves down to the right lower quadrant. When you push on the right lower quadrant, you should have pain. Well, there's Rovsing's, there's McBurney's, there's all these different points we learn in physical examination.
What a point named after me.
I know.
Although with my last name, it probably already is.
But couple of things. So you could have something called situs inversus or intestinal malrotation where your appendix is on the wrong side. So if you see a patient who hits all the right things and it's the wrong side pain, still check them, CAT scan them, ultrasound them, check.
Yeah, you could something else too, so it doesn't hurt.
It could be something else too, right? But it could also be just, or you can have apparently a very lengthy appendix.
Different sizes.
Apparently that can extend into the left lower. We're thinking usually it's the size of like a pinky, but I guess you can have a longer one. Sometimes males or infants and children can also have their scrotum on that size present as inflamed. Pregnant women, it's going to be slightly pushed up the pain because all of their organs are sort of moved around if it's late in the pregnancy.
It's funny you say that. I saw someone recently who said that, I don't think this is the correct terminology, that during her birth, her mother's appendix exploded.
Oh, fun.
Yeah, doesn't sound like a great experience for them.
No. So like we said, Rovsing is the right, is when you push on the opposite side. So I push on so McBurney's point is the right lower quadrant. Let me clear this up. McBurney's is the right lower quadrant. Rovsing is when I push on the other side, the left side, but it makes the right side hurt. And that's because of what we call peritoneal irritation. So that whole lining there, your peritoneum is inflamed. Another sign we use is so-called obturator. And I always remember this is obturator 4. You basically take your leg and you bend it and sort of, if you could picture your left leg being straight and your right leg being bent and rotate it out and make a number 4 with it. And that again shows irritation of the peritoneum. Psoas sign is the psoas muscles can be inflamed. So if you have the patient lift their leg and you sort of push against it, that also can elicit the same kind of pain. And what you'll often do in children, because it's tricky to sort of feel out what they're feeling, is ask them to jump. And if they don't want to jump, or if they jump and it causes the pain, that's another way to tell you that there's peritoneal irritation. So that's it. Those are just little tricks about how we know what it is. Nowadays, I feel like even though we are all trained in this very specific history and physical exam, like I said before, people often get a CAT scan the moment they walk in the door with an acute abdomen before the doctor even gets in the room, or PA or NP, whoever's seeing them. Other things we could see is blood work, your blood cell counts. So your white blood cell counts tend to be elevated. Your CRP, which is an inflammatory marker, is going to be elevated. You do always want to do a urine pregnancy test to rule out something like an ectopic pregnancy, a regular urinalysis to rule out something like a kidney stone or a kidney infection. So those are kind of the main things. As far as the white blood cell counts, about 80 to 85% will have an elevated white blood cell count. Predominance of neutrophils, which are typically the cells that fight bacteria. Less than 4% will have completely normal, perfect WBC count, white blood cell count. And elderly and young tend to slightly be different just because of those extremes of age. They don't always present exactly the same. CT scanning is really the gold standard, although bedside ultrasonography is now being used sometimes and is recommended by certain organizations. So the American College of Emergency Physicians does recommend ultrasonography for confirmation, but not exclusion. So it's quicker, it's easier. There's no prep to be done. You don't have to drink any contrast. It can be done very quickly. So you can rule it in very easily with ultrasound. You can't necessarily rule it out by a normal ultrasound. A CAT scan is a much better test for that.
Yeah.
And typically the management, so it's interesting, classically the management was always straight to surgery. That's it, surgery. Now there are some schools of thought where we can actually delay the surgery and do IV antibiotics and then discharge the patient oral antibiotics, let things simmer down, and then bring them back for surgery. And this is pretty recent in the past few years. The problem is there's not clear guidelines, and different surgeons are going to have different ones that they follow. One organization may say this, one may say that, one may go by their experience or their, old school. So it's not going to be across the board. Appendectomy, taking the appendix out, is still the only curative treatment. But they kind of break it down into a couple different ways. So a phlegmon, which is a little...
So I laughed.
A phlegmon.
So that's the phlegmon. My
phlegmon. Basically like a small abscess. We'll typically do IV therapy and then 4 to 6 weeks later take the appendix. A large, well-defined abscess, they'll do something called percutaneous drainage. So basically, you're just laughing at all the abscesses.
No, just like a well-formed one. That's a good one.
Well-defined,
Well, I'm a well-defined.
A well-formed
appendix.
So they'll drain it. They'll leave a drain in. So this is like a drain from the abscess to the outside of your body. And they can have some IV antibiotics. And then once that fistula is closed, they go back in. If it's a compartmental abscess, so sort of lots of lobulated areas. So an abscess, let's talk about that. That's basically a giant pimple. That's the easiest way to describe it.
Well, and is
inside.
Are those abscesses what causes the appendicitis, or is it an effect of the appendicitis?
So yeah, the appendicitis is caused by sometimes a hard calcified piece of stool, bacteria kind of get caught in there, and infection ensues, essentially. So an abscess in general is a collection of what we would call pus or purulent material, which is usually actually all of your body's white blood cells and all of its things coming to try and fix it. That's what the abscess is. But a large abscess, of course, is more likely to burst. A clear, simple circle with fluid in it would be a simple abscess. Multi-compartmental would have multiple different lobes and not fully formed. So, those are all the different options. I think it's going to depend on what center you present to and who the surgeon is and your particular situation. And, typically they do give antibiotic prophylaxis no matter what before. So you will get at least a dose, if not multiple doses of antibiotics IV prior to the surgery. And then usually it's very broad spectrum. You're covering our anaerobes because the bacteria that live in our gut are going to be anaerobic, which means that they don't require oxygen. So E. coli and Klebsiella, Enterococcus. These are the type of bacteria that live in your stool. Naturally, they live there, but obviously they're the ones who can cause this as well. And, once the patient is no longer having a fever, the white count normalizes, the antibiotics can be stopped. It is nowadays in modern day a very simple procedure, often done now not open, where they're cutting you open, but doing it laparoscopically, where they're making these tiny little incisions, unless it's something that needs a lot of cleaning out or it's very complicated. And most people go home same day or next day now. It's very simple. But if we think historically, all the old movies and old shows, people died from appendicitis.
Yeah.
So modern medicine, it's like no biggie nowadays.
Well, and I would imagine if someone doesn't present for care, you could probably still die from the after effects, the infection and things like that.
Oh, absolutely. Yes. If you are not evaluated, but if you are evaluated, it's pretty straightforward. You don't see a whole lot of complications. There's always a possibility, but it's very simple and straightforward. And with that classic presentation, nobody really should ever miss an appendicitis. I mean, if you went to school, you really should remember all those rules and presentation and catch it. I've definitely caught one in urgent care for sure and sent them to hospital. I think I might have caught two. I'm trying to remember, but sometimes people show up like urgent care or your just regular old office,
Right.
And you're hitting all those classic signs and symptoms like, yeah, no, you need to go get that urgent CAT scan at the hospital. I'm not going to wait on this one.
And it sounds like it's not something that you can do preventative for. It's not something like if you do X, Y, and Z, you're not going to get appendicitis. We'll just kind of...
Nope. Bad luck. Strike of lightning. Just happens. There's nothing that causes it. There's nothing you did. There's no diet that did it. It just is.
Good. Much like life. It just...
It just is.
Yes.
So that's it. That's appendicitis. I think today was a little short and sweet on episode 11, which is nice.
Well,
a little refreshing.
Short for us.
Sure for us. 45 minutes. That's not bad.
Yeah.
But hopefully you like our voices anyway and you don't mind.
I mean, I feel like we're talking about really interesting stuff and we're growing and we're learning and we're in this together. So everyone wants to listen to us.
Yeah. So definitely follow us on all our socials as we plug every episode. Please, please, please tell a friend. Follow us on Instagram, TikTok, YouTube, Facebook, Pinterest.
We're
Yes.
all social media platforms. Rate, review, and follow. And
Yes,
you can
please.
shoot us an email at medicalmediamixer@gmail.com. Still haven't received any emails. I get sad every time I open the box, but eventually they'll come through.
And also fill out our survey that's located in our show notes and on our website. And I think I've linked it on a few social media posts as well.
Yeah.
All right. So thank you for listening to Medical Media Mixer.
The perfect cocktail. Cheers.
Cheers. We actually have drinks left.